Hello and welcome to another emergency question and answers for families in intensive care and intensive care at home. My name is Patrick Hutzel. I'm your host today of the emergency Q&A for families in ICU and intensive care at home. I do this YouTube live stream every week on 10:30 or 10:30 a.m. Sydney, Melbourne time in Australia, which makes it currently 7:30 p.m. on a Saturday night Eastern Standard Time in the US, 6:30 p.m. Central Time on a Saturday night in the US, 5:30 p.m. Mountain Time in the US, and 4:30 Pacific Time on a Saturday afternoon in the US. In the UK, it's probably currently around just after midnight. Welcome to everyone watching this live, and welcome to everyone watching this on replay as well. Before we go into today's questions, I also want to excuse me for a second. I do have a little bit of a sore throat today. That's why my voice might sound a little bit odd. And I might have to keep hydrating regularly so that my voice stays moisture today. Anyway, what makes me qualified to answer questions for families in intensive care and intensive care at home? Once again, my name is Patrick Hutzel. I'm a critical care nurse by background. I have been working in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care since 2013 at intensivecarehotline.com, which I also founded in 2013 with intensivecarehotline.com. It's a consulting and advocacy service for families in intensive care. And I can very confidently say that we have saved many lives with our consulting and advocacy for families and for patients in intensive care. And you can verify that on our testimonial section at intensivecarehotline.com. And you can verify it on our intensivecarehotline.com podcast section, where we have done some client interviews to once again verify everything that I'm saying, because we have done some real world interviews with our clients that where we've saved lives. We even have a patient on one of our podcasts who was told they were going to die regardless. I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. With Intensive Care at Home, we are currently operating all around Australia. We are sending our critical care nurses into the home to provide a genuine alternative to a long-term stay in intensive care, predominantly for long-term ventilated adults and children with tracheostomies, but also for long-term ventilated adults and children without a tracheostomy, or for adults and children with a tracheostomy without needing ventilation. We also provide home TPN, home IV potassium, home IV magnesium infusions, home IV antibiotics, palliative care. We provide central line, PICC line, Hickman's line, and port management at home. We are also sending our critical care nurses into the home to provide emergency department bypass services, and we have done so successfully for the Western Sydney Local Area Health District in Sydney as part of their In Touch program. And when we send our critical care nurses into the home, whether it's to provide a genuine alternative to long-term stay in intensive care, we're improving the quality of life for patients and their families, but we're also saving the cost of an ICU bed by approximately 50%. And when we provide an emergency department bypass service, we're approximately saving $2,000 per ED admission that we can provide at home. It's all about improving quality of life for patients and their families, cutting the cost of a bed significantly, because ICU and ED beds are the most sought after beds in hospitals, and improving the quality of life for patients and their families. Okay, now Before I go into today's questions, I also want to do a quick summary of, what some of the work that we've done this week. And I actually want to start with one of the questions that we had this week that I want to read out. Just gotta give me a second. So let me go back to my emails here. And while I'm looking through the emails, so you would have seen that I've, if you're a subscriber to my YouTube channel or subscriber to my blog, you would have seen some of the videos that I've broadcasted this week. One of the videos that I think is a very important one is, what does a real end-of-life situation look in intensive care? And I encourage you to read through or to watch the video. It's a very important video, so you can understand what it would look like if your loved one was to die in ICU. So you can actually look up the signs, read the signs, because there's a big difference in intensive care between a real versus a perceived end-of-life situation. And you need to know, if intensive care teams start talking about end of life, you need to know whether your family member is in a real or a perceived end of life situation. And I have done plenty of videos around this topic over the years, but I've also described this week what a real end of life situation looks like, because one of our clients, unfortunately, had their family member pass away in ICU, and it was a real end of life situation and not a perceived end of life situation. So let me read out an email that we had this week from a client. Hi, Patrick. So this is a client who has their husband in intensive care. So I've just got another call from my husband's other doctor in ICU. They're really pressuring me. The doctor says my husband has a life-threatening hemorrhage. His hematocrit is 17. It was 23 yesterday and 26 the day before. They are giving him a unit of blood. The doctor says he will need more. The doctor also says they need to do an embolization procedure, but have problems finding where the bleed is coming from. Well, just to interject there, how can you do an embolization procedure if you don't even know where the bleed is coming from? Because you also need to know how risky it is to access, the location of the bleed. Is it in the brain? Is it in the stomach? Is it, at the kidneys, at the liver? You need to find out where the location of the bleed is before you can make a call whether an embolization is the best course of action. Then the email continues. They were also telling me my husband's blood pressure was low. I asked why they had him on 5 blood pressure medications yesterday if it was so low. He said, well, yes, that could have contributed to low blood pressure, but the bleed is why it's low now. Right, well, and I've seen the medication list. The client's husband is on a lot of antihypertensives, and we'll come to that list in a minute. And the combination of being on antihypertensive medication and the bleed will definitely get the blood pressure to plummet. There's no question about that. And that is what's happened here. Now it seems to get better with the antihypertensive stopped and with the red blood cells going up with the blood transfusion, but you immediately need to stop antihypertensive medicine if you are actively bleeding, or if a patient is actively bleeding. Okay, then the email continues. The doctor again pushed me for to sign a DNR. With the development of a spontaneous bleed, when they started anticoagulants. So he is now suggesting a conservative approach. Give blood, stop anticoagulation instead of embolization procedure. He could have another heart attack from this, and therefore they keep pushing for the DNR. I would appreciate if you could call me back ASAP after looking at everything, which is what I've done. I've spoken to the client yesterday. I will sign up for more consultation time as needed. So, then the email continues. And sorry, before I continue with the email, what's a DNR, by the way, for those of you who don't know what a DNR is? A DNR stands for do not resuscitate. And the DNR means or that if a patient's heart stops, they would not resuscitate and would let the patient die. That's what a DNR means. And from my extensive experience, you do not agree to a DNR, because once you agree to a DNR, they will wind things down. Even that's not what they're telling you, but you've got to watch people's actions, not their words. And their actions would always speak when there's a DNR, that they're winding things down, that it's the first sign to a withdrawal of treatment. That's why I am so opposed to a DNR full stop. Now, the email continues. I am not ready to make my husband a DNR. And they keep pressuring me every day. I am solid on giving my husband a very reasonable chance to recover. I'm also waiting for a call back from a law firm to see what I can do about getting access to medical records, etc. I will attempt to provide you with as much pertinent information as possible. I took some pictures of my husband's monitor, ventilator, and other data, which I will send in a separate email from my phone, which I have obviously access to. My husband was admitted on the 8th of October, had shingles for 2 weeks, falling down for the past 2 days, headache, and then we called the ambulance. He had a seizure in the emergency room, and they asked my permission to put him in a medically induced coma. No one attempted to even call me until the next day. I found out from the RN they didn't put him on antivirals until day 3 for the shingles. On the 9th of October, I was notified that he's now intubated and in ICU. On the 14th of October, my husband had a cardiac arrest and he was brought back in 5 minutes. The ICU nurse told me that his electrolytes may have been off when I asked why. And that might have been the case. Some patients go into cardiac arrest when their potassium is off, right? Also, I found out later they were doing a breathing test for the first time, and he got tachycardic. They're much more careful since then to watch his heart and breath rates when doing this. Yeah, that all makes sense. That all makes sense that maybe it was coinciding with an imbalance in electrolytes, potassium, magnesium, and maybe it was also coinciding with pushing a spontaneous breathing trial too hard. Might have been the case. I just had a call from Dr. So-and-so, who's once again doubling down on me to make my husband a DNR. The doctor rotated in on Sunday, so this is her 6th day on the case. She said she sees no improvement since she came on shift last Sunday. They keep pressuring me. What would my husband want? This is not about what you want, they keep saying. This is about my husband's quality of life and could he live with it. I told her to stop with the fear tactics once again. I'm well aware. I need time to make an informed decision. She clearly doesn't like that I am not taking her word for it. She's worried my husband will be institutionalized for the rest of his life. She said that if my husband had another cardiac arrest, would I allow a DNR? I said no. Then on with the guilt. So, this is today's update from the ICU doctor. So my husband developed blood clots in his arms, and they gave him anticoagulation, Lovenox. He now has a bleed which they haven't located. They are giving him blood today. They're doing a CT scan. His white cell count had improved, some down to 22,000. Now it is back at 36,000. Just for the records, a normal white cell count is between 4,000 to 11,000. He did have a previous UTI, urinary tract infection, which I understand cleared up. They have not been able to find the source of this infection. Could it still be from the encephalitis? Potentially, yes. So, the bleed and the infection and increased white cell count were the reasons the doctor was pressuring me again. Well, you should not be pressured by anyone. You need to make decisions that are in your best conscience and in your best conscience only. And you need to make decisions in the best interest of your husband and in what he would want to decide. They keep threatening you that, he might be institutionalized for the rest of his life. Well, that may be the case, and you definitely need to weigh up whether that is something you or your husband would want. But there's plenty of people living in institutions that actually do want to live. So you got to question the narrative here, right? And you got to make your own decisions. You got to think for yourself, which I know you're doing. So the email continues. So the bleed and the infection and increased white cell count were the reasons the doctor was pressuring me again. She told me her role is to tell me what's happening, and my role is to do what my husband would want. And I told her I'm doing research and I need time to make a reasonably informed decision, and I won't be pressured, so I suggest you just stop. It's been really bad since the day after my husband had the cardiac arrest. I spoke with the cardiologist 3 days ago, and his heart is back at baseline. He feels he is at minimal risk for another cardiac event and feels he was doing well overall. His left ventricular ejection fraction is back to 50%. He was diagnosed with a stress-induced cardiomyopathy, which I know can heal in a few weeks. We were also told he's in heart failure. That is no longer true. Of course, they didn't voluntarily let us know these things. I had to ask. Cardiomyopathy, in essence, is heart failure, right? If ejection fraction is back to 50%, that's a good sign. After cardiac arrest, ejection fraction can go as low as 25%. Basically, ejection fraction is referring to the contractility of the heart, the pump function of the heart. And if it's back up to 50%, it's not quite back to normal yet, but it's coming back to normal. So, the email continues. This doctor also told me that his blood pressure was low today. I said, I'm aware you have her on 5 high blood pressure medications. She added 2 more yesterday that my husband had been taking at home. The RN said the goal was to keep his blood pressure below 150 systolic. They restarted spironolactone, 25 milligrams yesterday, amlodipine, 10 milligrams, hydralazine, 25 milligrams 8 hourly, losartan, 25 milligrams daily, metoprolol, 50 milligrams every 6 hours. Well, especially metoprolol, 6 hourly, 50 milligrams, that's a lot. As you can see on the pictures I sent you, his blood pressure was quite low last night. The bells chimed and the nurse had to give him something to bring it back up. All these blood pressure medications make no sense to me. Well, they make sense if he came in with high blood pressure, but they don't make sense if he's got low blood pressure now. They need to fix the bleed. They need to stop antihypertensives. So, I found out last night they didn't start him on acyclovir for the viral infection, or what was it you mentioned in the beginning? I have to scroll back. You mentioned a viral infection in the beginning. Where is it again? Shingles, that's right, for the shingles. So, yeah, so I found out last night they didn't start him on acyclovir until day 3. They also didn't give him TPN until about day 11 to 12. I kept asking, how can he get well without nourishment? My husband has kidney agenesis. However, I told his kidney is functioning well today. As per the nurse last night, the fever is 38.4 Celsius. He has been running a low-grade fever continually since diagnosis with pneumonia, which is clearing up now. His last CT of the lungs looks good, I am told. The lung secretions have been white or clear recently. He's still on anti-seizure medications. He has not had any more since being in ER and has had 3 EEGs now, not showing any anti-seizure activity, and swelling is down in the brain. What other info should they been telling me from the EEG? Dr. Plotkin said she doesn't think my my husband can have a good recovery, would likely be institutionalized for the rest of his life. So how can he get well without nourishment? Well, he can't. He can't, right? There's enough research out there that a critically ill patient in intensive care needs nutrition from day one. There's enough research out there that with early feeding, early nutrition, the mortality rate for ICU patients is decreased and the survival rate is increased. So it shouldn't even be a matter of discussion. It's good that he's on TPN now, but why is he on TPN? You haven't shared anything with me so far why he is on TPN. TPN stands for Total Parenteral Nutrition, also known as IV or intravenous nutrition, right? And I'm glad to hear that he's on that. So, then the email continues. Lung secretions have been white or clear recently. He's still on anti-seizure medications. Oh yeah, no, we've got that. His morning venous blood gases were good per nurse, no ventilation changes. On anti-seizure medications, Keppra, 1250 milligram 2 times a day or every 12 hours, and valproic acid 500 milligrams every 8 hours. On cefepime 20 last dose. On acyclovir started on the 10th, third day. Propofol for sedation continues. They gave him fentanyl for a spontaneous breathing trial and giving it to him PRN. Well, anti-seizure medications also make patients drowsy, which means that on top of the propofol, the fentanyl, he's less likely to wake up, right? So they need to stop all benzodiazepines, propofol, opiates. One of the issues with fentanyl is one of the main side effects of fentanyl is to cause respiratory depression. Respiratory depression means that spontaneous breathing is inhibited. Now, when you want to wean someone off the ventilator, which is absolutely the goal in this client's husband, you need to stop opiates, right? That would be the ideal scenario. Now, also, the email continues. My husband was able to breathe on his own for 1 to 1.5 hours. Yesterday has been running up to 3 hours previously, and as low as 5 and 10 minutes, but it's not consistent yet. Please tell me what other info I can provide to you. Nurses are good about answering my questions. I would like to have a consult with you ASAP, which we've had. And please let me know when you're available, which I've communicated to you. So I'm not mentioning any names here. So anyway, never ever agree to a DNR. Never ever, because what that means is the ICU will withdraw treatment as soon as you've signed a DNR. Yes, that is not what they're telling you. They will giving you all sorts of euphemisms, but in the end, that is what they will do. And by you agreeing to a DNR, that will be the first step of ICU moving towards a withdrawal of treatment. And I strongly, strongly advise, don't do it. Now, we're currently helping this client to get through that. And this is the email that came through yesterday. But interestingly enough, I had a text from this client this morning where she's basically saying her husband is now more awake and waking up, which is fantastic. He's obeying commands, which is fantastic. And it's also a sign that, clinical judgments from intensive care teams can be so wrong. And what if their clinical judgment is wrong? I will have another email later where intensive care teams kept telling one of our other clients that their father is passing away. And that's a while ago, but it's sort of something that came to mind to me this morning, where I was thinking what would be a good example. And and their father now is at home, right? And that's intensive care. So telling them, oh, he won't survive bowel surgery, he won't survive a central line placement, he won't survive this, he won't survive that. All doom and gloom, right? To create a narrative of death, right? Without actually, giving people a go, giving it a good shot and see what's actually happening in the real world. And like I said, you got to watch people's actions, not their words. More important for you to watch people's actions, not their words. Now, one part of what I mentioned a minute ago is obviously that this particular client from this email had TPN. Now, when is TPN actually needed in ICU? Well, TPN in ICU is when patients can't digest food. They might have absorption issues, they might have digestion issues, they might have had bowel surgery, they might have an ileus or a bowel obstruction, and they can't have enteral or oral feeds because of that. That's when TPN comes in handy. TPN stands for total parenteral nutrition. Basically what it is intravenous nutrition, right? And with intravenous nutrition, right, you need a central line or a PEEK line or a Hickman's line or a portacath to deliver intravenous nutrition, right? Because it needs to go, it's such high concentrated that you couldn't give it peripherally. It would only cause pain and for the patient, right? Now, this week also, we were working with a client who had their family member at NYU Langone, and I do have permission from the client to share the name of the hospital. And I do believe in this instance, we do actually need to share the name of the hospital. So we had a client at NYU Langone, which is in New York, right? So here's the situation. A 90-year-old man was in ICU with a stroke and respiratory failure. He was intubated, and then he got extubated, and he was put on BiPAP. It was a risky extubation, I will say that. A very risky extubation, which is why he ended up on BiPAP within sort of 24 to 48 hours of extubation, right? And then they kept him nil by mouth, right, because of the BiPAP. And part of the issue was his level of consciousness wasn't the best, right? So he was at high risk of aspiration, not only because of his decreased level of consciousness, he was also high risk aspiration because of his, weak cough and so forth. So we then advocated early on to get this man on TPN because, critically ill patients in intensive care need nutrition. They stopped his nasogastric tube, just before they were extubating him, which makes sense, right? And he was on nasogastric tube feeds before he became extubated, right? So that was all fine, but then as time went on, as he was on BiPAP, we kept asking for TPN because they still didn't want to feed him, said it's too risky, and they would only feed him if they could intubate him or re-intubate him. It was almost blackmailing the family, which is completely inappropriate to blackmail a family in a situation like that. And what happened from there is, we kept arguing that TPN or intravenous nutrition would be the right course of action here, and they kept denying it. Now, the family took the case to court, right? But by the time, the court was sort of responding to the family's request, the patient actually died, right? And I do believe it is fair to say here that NYU Langone in New York, let the patient die without nutrition. Could argue starve the patient to death, because in the end, it would have been around 8 or 9 days without nutrition for a patient who desperately needed nutrition, right? Because they were fighting a critical illness. They were getting weaker and weaker by the day as they were on getting BiPAP, right? That is extremely, extremely concerning, right? And it's just not appropriate, right? So that is massively concerning to me, and was massively concerning to me and the family, because an ICU is basically denying a patient basic human rights, which is nutrition. Nutrition is a basic human right, even when patients are dying in ICU, in a real end-of-life situation. The last thing you would take away is actually nutrition. You wouldn't take anything else. You might take other things away even prior, but definitely not nutrition. Nutrition is a basic human right. Okay, and we recommend that this hospital needs to be taken back to court for denying a patient a basic human right. That is up to our client, of course, to take the next steps, whether they want that or they don't. But I believe it is absolutely imperative that they do that, right? So now that I've got that out of the way, I'll also want to quickly run through the videos that I've made this week. I want to point you towards the right videos for this week. Just give me 1 second. I just quickly need to look through what we've done this week. So one of the videos that I think is a really important one is what is a real end-of-life situation in intensive care and critical care. That one I think is a really important one. And the video will focus on what does it look like when someone is dying in ICU. And unfortunately, we had one of our clients' family members pass away in ICU this week. But by the same token, we were satisfied that the ICU was doing all the right things, and we were satisfied that there were no human rights breaches, right? Unfortunately, the client went into multiple organ failure, basically had to be taken off dialysis, because if dialysis had continued, the blood pressure would have plummeted even quicker and the patient would have passed away even quicker. The heart shut down. What that means is patients would be on multiple inotropes and vasopressors at the maximum levels, right? That is what that looks like. Also, and when I talk about maximum levels of inotropes or vasopressors, I'm talking about levophed, norepinephrine, vasopressin, dobutamine, milrinone, all the stuff that normally keeps people alive in ICU was at the maximum level, and it couldn't have been run at even higher doses, right? So kidney was failing, liver was failing, and the lungs were failing, because the gentleman also was on 100% FiO2 oxygen levels, and also on very high PEEP levels, and the blood gases were just deteriorating by the minute, with lactate being extremely high in this situation, right? So that's actually what a real end-of-life situation looks like. And that's also a situation then when even I say, when there's nothing else that can help a patient, that's when you could actually confidently, sign a DNR, but not before then, before all the signs are there. There was also a pH imbalance. pH was getting lower and lower because, CO2 was creeping up. And that was also a sign that the patient was unfortunately dying. Okay, then let's get back to some other emails from the week. Here we are. So, one of the emails that we had from, just give me 1 second, please. Oh, where's the email now? Can't find it. Can't find it now. I do apologize. Bummer. Can't find the email now. Ah, that's why. It's in the wrong. Okay, here it is. Here it is. So this is actually a client that we worked with last year, way back when. And I think it is really, really important. This is a client who was in ICU with a bowel perforation, and he was in his 80s at the time. I remember that. He was very frail, very, very frail man. And his daughter was his next of kin and power of attorney in the ICU. Was giving her the death talk. They were telling her, let's not bother about doing, bowel surgery. He won't survive, and all the rest of it. And let me go through some of her emails, and I will also talk about the outcome, how it ended up, So let me read out one of her emails. Hi, Patrick. I just wanted to update you on the latest. Believe me, I am trying to stay positive at all costs. I spoke with the ICU doctor. He approved the TPN and said it does have risks like infection, etc. He also spoke about intubation if oxygen levels get worse. Like this was a client, his airway was hanging at a thread. He was on non-rebreather masks. He was on and off BiPAP. And we were very worried at the time that if he would get intubated, because he was so frail, he would never get off the ventilator. He mentioned that if he gets through this, his quality of life may never be the same, and he may end up in a rehab for the rest of his life. I could be wrong, but I believe this was again to push the DNR narrative, right? Once again, I would never give consent to a DNR unless it is a real end-of-life situation, like I explained a minute ago. Then the email continues. The second doctor of the day came by and said his lungs sounded stronger. The doctor seemed more positive. We talked about TPN, and she was also against it. She said this is not something that's used anymore. There's no need since he has a perfectly healthy GI tract. She was afraid of the harm outweighing the benefits. She told me this will completely suppress his appetite and is not sustainable. So we called in the nurse to discuss further. The nurse said because of the hernia, the doctor is not attempting the feeding tube at this time. The only alternative is to surgically put the feeding tube into his stomach. But he will most likely die during this procedure. The doctor then went from positive just 10 minutes before to agreeing with the nurse and saying my father is not going to survive this because of all the cases they've seen. They know the big picture and ultimately outcome. They then started the DNR narrative again. So this is how we started working with this particular client. He actually had TPN in the end. He survived and he went home a few months later, and he's still around, and he's in his 80s. And this is ICU's telling the family they wouldn't survive, procedures. Now, here is another thing that I want to clarify here for once and for all. They're saying the risk of TPN or the risk of giving TPN is too high for an infection. Now, there's two things there. Number one, that's like a healthy person saying, well, we stop eating and drinking in case food or drinks are contaminated. Right? It's not any different here. So let me tell you what TPN is. TPN is total parenteral nutrition. It's intravenous nutrition. It comes in a bag. And when it comes in a bag, right, it gets hung to a central line or a PICC line or a Hickman's line or a port catheter, right? Is there an infection risk? Absolutely there is. 100% there is, right? But once again, that's like saying, well, we stop eating and drinking in case food or water is contaminated. There's always a small risk that food or water might be contaminated. Of course there is, but the risk is low. In ICU nurses know how to manage TPN so that there won't be an infection. It's just a skill that can be learned. That's all it is. Right? So that's all it is. So then, to carry on, and this is also what NYU Langone said this week when I was talking a minute ago, that a patient died there this week, that they were literally starving to death. They were saying there's too high risk of an infection. Well, the patient died because he didn't have any nutrition. One could argue that's medical negligence. It is starvation. Question is it murder? Is it homicide? Is it murder? I'm not a lawyer, but I do believe the questions need to be answered here, and people need to be held accountable for their negligence. Right? To give you more perspective around TPN in particular, right? And one of the doctors in this email also saying, well, TPN is not used anymore. What a whole lot of nonsense. What a whole lot of rubbish. We have clients in the community, right, here in Australia that are on home TPN. Why are they on home TPN? Because they can't eat and drink. They can't have a nasogastric tube. They can't have a PEG tube simply because they're not able to digest food, right? That is when a patient needs TPN, right? So there's patients living in the community on TPN for years and decades. That is their only form of nutrition, and it keeps them alive. And they have a central line, and yes, there is an infection risk. Yes, there is. Not denying that, not disputing that, it just needs to be managed. That's all. Just like, the potential for food contamination needs to be managed. Right? So, TPN is an absolute option for someone who can't eat and drink, can't have a nasogastric tube, can't have a PEG tube. TPN is the solution, right? So, and read up, indications for TPN. See what you find. So, then, what else is there? So then another question that came in is, hi Patrick, thank you so much for talking to the nurse and the doctor. After the call, this is from another client, after the call I stepped in to see my grandma. She was opening her eyes and even moved her legs a bit. They went to suction her, and you can tell that it causes a lot of discomfort because she opens her eyes, opens her mouth, and tries to move a little bit. The respiratory person who did the suctioning said, that's the most awake he has seen my grandma, and that he had ran a spontaneous breathing trial, and she actually did really, really good. It's just that she can't protect her own airway. What does that mean? Yeah. So what does not being able to protect her own airway mean? So let's dissect this a little bit in a little bit more detail, right? So this particular, the client here, her grandma is in ICU. They want to wean her grandma off the ventilator, so they're doing spontaneous breathing trials. And it sounds like she's doing not too bad with the spontaneous breathing trials. However, if she can't protect her own airway, it'll be very difficult for her to be extubated. I have wrote an article and made a video, how to wean a critically ill patient off the ventilator and the breathing tube. And you can, read that article and video if you type that into Google or if you go to intensivecarehotline.com and you use the search box, how to wean a critically ill patient off the ventilator and the breathing tube. So what needs to happen to wean someone off the ventilator and the breathing tube? What needs to happen is patient needs to be on minimal ventilator settings, on minimal support, needs to have passed spontaneous breathing trials, needs to have minimum suction, needs to be awake, needs to be alert, needs to obey commands, right? Have good arterial blood gases on spontaneous breathing trials, right? Chest x-rays need to be clear, right? But they also need to be able to protect their airway. What does that mean? It means they need to have a good, strong cough. That's one of the ingredients. And they need to be able to swallow. If they can't cough, if they can't swallow, they can't protect their own airway, right? So imagine you can't cough. Saliva, food might drip down your lungs, causing an aspiration pneumonia. If you can't swallow, the same applies, right? Because swallowing reflex means it's automatically going into your stomach. If you can't swallow, chances are saliva, food, whatever the case may be, will go into your lungs, causing aspiration pneumonia. Right? That is unfortunately what happens in situations like that. So then after that, there was a follow-up email from this client who says, hi Patrick, so ICU is telling us to make a decision. I think we want to move forward with the tracheostomy, but they are saying that depending on my grandma's insurance, they have to make sure an LTAC would accept her. We would want her to remain in ICU for as long as possible, but how can we do that? I feel they would get defensive by us demanding that. Yeah, there's no issue there at this particular point in time because I know your case very well, so I can give a very detailed answer here. What you do if your loved one needs a tracheostomy, let's just say your loved one needs a tracheostomy, there's no way around it, right? What you should be doing is not give consent to a PEG tube. Now, this is unique for our clients in the US, right? If you're in the US and you're watching this, and ICUs are asking you to give consent to a tracheostomy and a PEG tube, do not give consent to a PEG tube. Very, very simple. Do not give consent to a PEG tube. You can give consent to a tracheostomy after you've ruled out that ICU has done everything beyond the shadow of a doubt to get your family member off the breathing tube. Right? That's the only time you can actually confidently decide and give consent for a tracheostomy. Right? So, and then also, by you not giving consent to a PEG tube, right, your grandma most likely will stay automatically in ICU anyway, because no LTAC will take, or very few LTACs will take patients with a nasogastric tube instead of a PEG tube, right? If you're watching this and you are in other countries like Australia, UK, other English-speaking countries, a PEG tube after tracheostomy is usually not happening. A nasogastric tube will stay in place because it's very safe. A PEG tube placement is a surgical procedure, and there's no need for it. No need for a surgical procedure, right? A nasogastric tube can stay in for months on end. Once again, with the right care and skill, no need for a PEG tube. In the US, the PEG tubes are only used to push patients out to an LTAC. It's the only reason why PEG tubes are used in the US. Right? In other countries, people stay in ICU until they can be discharged or until we can take them home with intensive care at home. And you will find more information at intensivecareathome.com. So, what else is there to consider, right? The other thing that you should consider here is the advocacy to keep a patient in ICU. Once again, there's enough literature out there to suggest that no one can leave ICU without consent if they're not ready. Now, if they're ready, that's a different story. But when patients go from ICU to LTAC, I can assure you they're not ready. They're absolutely not ready. Right? Because so many patients have bounced back into ICU in no time. We've seen this over and over and over and over and over again. That patients bounce back into ICU in no time. Don't do it. Don't do it. Right? And, you know, there's a podcast that I've done the other day, a couple of weeks ago, where I've interviewed one of our clients, where we've done exactly that. We've helped them to advocate not give consent to a PEG. The client needed a tracheostomy, and then we helped them to keep them in ICU until the ICU weaned them off the ventilator and the tracheostomy successfully, because that's what ICUs do best. Right? That's what ICUs do best. Right? Also, as this particular client was moving towards a tracheostomy, the next email from the client says, "Hi Patrick, so I've let the nurse and doctors know as of 2 days ago we want to proceed with the tracheostomy and not the PEG tube. Since then, every time I call or visit my grandma, the topic is brought up. Every nurse is asking me why, is telling me that it's in my grandma's quote-unquote best interest. However, I have simply told them we are just not ready to have that procedure done for my grandma. Earlier today, an ICU doctor called asking why we didn't want the PEG tube done, if we had any concerns. My question is, if they find an LTAC who would take her with a nasogastric tube, what would I possibly do to keep her in ICU? Why would I then ask for a discharge policy? I would also like to add that the tracheostomy has not been done, and it probably won't be done until Monday, Tuesday, because from what we were told, she needs to be off Plavix for 2 to 5 days. Today was day 1 of her not receiving that medication. Fair enough. If she's on Plavix, definitely needs to stop Plavix, otherwise she's at high risk of bleeding. Plavix is an anticoagulation drug, and it's making patients bleed. Well, ask them for the discharge policy. You will see that the hospital discharge policy will say something that a patient can't go without patient or family consent, right? And they keep putting pressure on you because you just stand out from the crowd, because everyone else is just nodding everything off without questioning. You're not one of them, which is good, right? So, and also there's research out there to say that a nasogastric tube is much safer than a PEG tube, much safer, right? So, and I want to conclude it there today. Like I said, I do these YouTube lives once a week. If you like my videos, give this video a like, share the video with your friends and families, subscribe to my YouTube channel for regular updates for families in intensive care. You will also get a notification for the YouTube live. Click the like button, click the notification bell, comment below what you want to see next, what questions you have from this video. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. We also have created a membership for families of critically ill patients in intensive care. And you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. In the membership, you have access to me and my team 24 hours a day in the membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I have personally written and recorded that will help you to make informed decisions, have peace of mind, control, power, influence, making sure your loved one gets best care and treatment. Now, I also talk to you and your families directly. I talk to doctors and nurses directly as part of the one-on-one consulting. When I talk to doctors and nurses directly, I ask all the questions that you haven't even considered asking but must be asked when you have a loved one critically ill in intensive care. We also do medical record reviews in real time so that you can get a second opinion in real time, and we also do medical record reviews after intensive care. If you have unanswered questions, if you need closure, or if you are suspecting medical negligence, all of that you get at intensivecarehotline.com. With intensive care at home, like I said, we are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are sending our critical care nurses into the home for long-term ventilation, tracheostomy, long-term ventilation, BiPAP, CPAP without tracheostomy, 4 tracheostomies without ventilation, home TPN, home IV potassium, home IV magnesium infusion, home IV antibiotics. We manage ports at home, central lines, Hickman's lines, peak lines at home, right? And we also provide emergency department bypass services. We are an NDIS approved service provider, TAC WorkSafe in Victoria, ICARE in New South Wales, NIISQ in Queensland, DVA all around the country. We are also receiving funding, or have received funding, through public hospitals, departments of health and private health funds. Now, we're also providing level 2 and level 3 NDIS support coordination, as well as TAC case management in Victoria. We are also providing NDIS nursing assessments. We have critical care nurses that do NDIS assessments. They also have a legal nurse consulting background, right? And if you're a critical care nurse looking for a job with intensive care at home, reach out to us at intensivecareathome.com. We are also expanding our medical team. So if you're an ICU consultant or ED consultant, we want to hear from you. We can also help you to keep your ICU beds and ED beds empty, or free up your blocked ICU and ED beds. So once again, please reach out at intensivecareathome.com. If you're a hospital executive watching this and you need help with emptying your bed blocks in your high acuity areas, we are there to help you. In most cases, you won't even pay for it. Reach out to us at intensivecareathome.com. Call us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. Thank you so much for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com, and I will talk to you during the week. Take care for now.